So let's dive into, we did get to talk a little bit about the earlier stage disease, and I think we'll come back to that when we talk about ctDNA, and I definitely want to spend some time for us talking about ctDNA. But let's move to like the most relevant biomarkers, and I think really exciting to see now biomarkers coming into the first line setting. So let's start with MSI-High testing, or MSI-High patients. And so let's, I think previously we had, Keynote 177 and monotherapy data, and I think we saw rapid uptake given the remarkable data we saw with there. And then over the course of the year, we've seen really exciting data with dual checkpoint inhibition with ipi/nivo. So what's the adoption? How has that gone in clinical practice? And are you using doublet therapy for everyone now, or there's still patients that you're choosing monotherapy for? Let's talk about that a little bit.
Yeah, go ahead.
Oh, I was just going to say, before this week, I feel like I felt a little bit more like you had the choice between Pembro or ipi/nivo, depending on how intensive therapy you thought your patient could tolerate or what really made the most sense. But, I think the ipi/nivo data is getting more and more compelling. It's pretty hard for especially your younger fit patient to think you would give them a different regimen just because it's such an impressive response.
It really is, and it's the tail of those curves that are so compelling. And I think the idea that a not insignificant number of those patients that are alive without progression at 2 years are really cured, right? And I think the data is maturing enough that I think should feel comfortable using that word. We don't like to say the word cure because but I really do think that is. And so, in my mind, that mindset has really been the big switch to say, when you're talking about curing, another set of patients, then that really, that modest difference in toxicity in the early part of the treatment becomes less concerning when you really have that cure goal in mind.
Talking about, are there any patients that you would give monotherapy to now?
I mean, I do feel compelled by the nivo-ipi data. Obviously, the data is very compelling. There are some, frail patients that maybe I have to think twice about. So I would still consider some pembrolizumab in that setting because I've had patients that have been cured, long-term survivors. So, there is efficacy of therapy as well. And I think, as we all know, not every therapy is for everybody. But nivo-ipi data is very, very compelling.
Yeah, and I think it's interesting too, even surgically, right? I feel like even a few years ago we used to take the oligometastatic MSIs to surgery too, and like we're not doing that anymore because, to your point, like you take them to surgery and there's no cancer.
Yeah, it's just scar tissue. Yeah. And I think that's such an important point that I know there's always still angst about. It's like, well, it's been 2 years of treatment, but I still see something on the scans, right? Like, should I really stop? And
ctDNA?
I think, ctDNA, but I think just having the confidence to say that, the experience has been, and it's really clear that these, at 2 years, like this is not viable disease, right? And so with very rare exceptions. So we still monitor them, but I think really it's that comforting message that we can give to the patients to say, we should stop at 2 years and just keep monitoring.
Well, I think then the next question also is, do they all need 2 years,
Well,
right?
right.
So I mean, now I think we have...
Because melanoma.
Right, and we've shifted the pendulum in a positive way, and I think everyone's always scared to scale back, but I do think that there's patients that might have only needed 6 months or a year. And certainly as we think about toxicity of dual checkpoint inhibitors, some of that's going to be early and some of it's going to be with prolonged exposure. And so I wonder if that'll be the next exploration that we can do.
Yeah, and I saw that 8HW data where the different toxicities by different timeframes. That was a really compelling figure. Right, and I think one I'll be pulling up and sharing with the fellows.
Watch out, Dr. Kopetz is back from ASCO. Fellows, exactly.
And I think one thing that came up that's kind of really interesting is like, what do you do upon progression, right? So like, do you do an alternate, checkpoint inhibitor, or if they were only on nivolumab, do you add ipilimumab on progression? I think the data is just not there, and so kind of, convincingly. So I think, again, what you do kind of first matters was my takeaway. But obviously, more clinical trials are needed for kind of the post-immunotherapy progression kind of space, because we know those patients don't respond to chemotherapy.
I think there's some interesting things in early drug development in that space, even though it's patients do well for so long, so it's going to be a little bit tricky to accrue, but there's some things I think brewing which will be great. Is anyone using ctDNA in this setting to monitor patients with IO response?
I have not been utilizing it as much in this setting.
You're nodding. Yeah, you are. Like, so baseline and then
Yeah, so a lot of times, so feeling a little more comfortable and being able to kind of feel out the pseudo-progression. So usually it's not early, but it's kind of that later one, especially as brought up, like patients that are having some toxicity at a year, and we want to kind of think about, do you go to year 2 or do you stop after year 1? That's the time that I'm pulling that up. And then, as you mentioned, some of those patients need that extra reassurance at year 2, because the radiology report will still say, stable disease seen in the peritoneum, right?
But don't you get a PET scan on your patients in that setting too? I found that to be a bit helpful.
That's not a bad idea,
I
actually.
found it to be helpful for those patients that still have,
reassure.
those that have like questionable disease on a CT scan, and then you do a PET and it's not active.
No, that's a good point.
So you can use both.
I mean, I think it also shows that we need reassurance as much as our patients do for stopping, that we're like also a little bit scared about screwing it up.